This is certainly an incredibly stimulating period for implementing innovative therapies in the field of B-cell precursor ALL. In particular, immunotherapy is experiencing a period of renaissance in the sense that there are several outstanding approaches which can really impact on the natural course of the disease, improving the already excellent cure rate of these patients. We now have available immunotherapy based on antibodies and also on cell therapy approaches. The most promising antibodies used in the arena of BCP-ALL are represented by the bispecific T-cell engagers, and the prototype of these antibodies is blinatumomab, and the antibody drug conjugate, and the prototype is inotuzumab, which is a drug now under investigation in Europe in an academic trial. Blinatumomab has proved to be extremely effective in patients with very advanced disease, namely those children who had experienced 2 bone marrow relapses or had a refractory disease or relapse after stem cell transplantation, and now is going to be tested also in the first relapse for the high-risk patients, and even in the frontline treatment, because the IO-BFN trial, which has just started a few weeks ago, will randomize medium and high-risk patients to be treated with blinatumomab with the goal of improving the probability of event and disease-free survival, respectively. And CAR T cells are the extreme frontier of immunotherapy based on the genetic modification of the patient's T lymphocytes through the introduction of a construct which permits to have a chimeric antigen receptor redirecting T cells against the target molecule expressed on leukemia blast, in particular against CD19, which is an antigen expressed in 99% of B-cell precursor ALL of childhood. Of course, we don't have to scotomize to underestimate the great results that we have obtained with chemotherapy, because, as I mentioned before, we are now able to cure around 80-85% of patients with frontline therapy, but there is still need to develop innovative therapies, because we have reached the top of the intensity that we can use with cytotoxic drugs, and because there is still a subset of patients failing conventional treatment. This is the right period for testing these innovative approaches, and in the future there will be certainly the room for larger use of immunotherapy also in newly diagnosed patients. Also, transplant has demonstrated to be able to rescue a large proportion of patients failing conventional chemotherapy. In the next years, we will compare what transplantation can offer in comparison to CAR T cells, and at the end we will be able to choose the most effective and also safe procedure for children failing conventional therapies. But of course, transplantation for the time being still has a relevant role in the cure of relapsed refractory patients with BCP ALL.